Hi, everyone. Welcome to our virtual health series with UC Health. My name is Hannah Parrott, and I'm the event coordinator with the Highlands Ranch Community Association. We are so excited that you all took the time out of your evenings to join us tonight to discuss heart health. We are grateful for UC Health Highlands Ranch Hospital as a community partner and happy to host this event with their wonderful assistants. Before we get started, I would like to go over a few housekeeping items. During the webinar, your microphones will be muted. To ask questions, please type them into the Q&A chat box. This can be found in your control panel on the bottom of your screen. We will save the questions for the Q&A portion towards the end of this event. Our presenter this evening is Dr. Steve Simon from UC Health. Dr. Simon is the Assistant Professor of the Division of Cardiology at the University of Colorado School of Medicine, UC Health. And now, without further ado, I'll pass the time off to Dr. Simon.
Great. Can everyone hear me? Let me see if I have control of the slides. Great. Thanks for the introduction, and thanks to everyone for joining tonight on this snowy January day. As mentioned, I'm Steve Simon. I'm an assistant professor in cardiology at the University of Colorado and practice through UC Health with my primary clinical practice in the Lone Tree Center. I am particularly interested both in clinical and research in the prevention of cardiovascular disease, both for those without existing cardiovascular disease and in those who already have in terms of preventing future events. And in that sense, that's going to be a lot of what I'm talking about tonight, given that it's the beginning of the year and a lot of people are kind of reflecting on goals for the coming year. I figured it would be nice to give a broad overview of what it is that causes the progression of cardiovascular disease and changes that one can make without a physician in terms of lifestyle to delay or block the progression of cardiovascular disease. This is likely going to stimulate a lot of questions, which I'd be happy to answer tonight, or can send me a message as things come up. It's a lot to cover, and nothing's going to be in too great of depth, so we can dive into that in the Q&A or at a later date. So starting with what causes cardiovascular disease, and here I'm talking about coronary artery disease or atherosclerosis, which is plaques in the heart arteries leading to heart attacks and strokes. And there are generally thought to be 7 primary risk factors for the development of this, and it's by the American Heart Association. They're called the Simple 7. 7 modifiable risk factors that can that lead to the progression of atherosclerosis. We're going to talk about each of these in terms of how it occurs, what it means, and how it leads to this progression of atherosclerosis. In addition to the AHA Simple 7, which I have listed here as hypertension, which is high blood pressure, hyperlipidemia, which is high cholesterol, prediabetes or diabetes, which are elevated blood sugar, obesity, which is an elevation of your body mass index, inactivity or lack of exercise, diet and nutrition, and the use of tobacco. In addition to those 7 modifiable risk factors, we'll just mention at least a couple others. So genetics and family history play a big role here as well. It's not part of the Simple 7 because you can't do anything currently about your genetics and family history, and so there's not much to modify. Inflammation is increasingly recognized as an important factor here, but the data is just a little bit delayed in terms of actually incorporating as an established risk factor for cardiovascular disease. In terms of the lifestyle modifications that we're going to talk about, they're broadly into 3 categories. So those are exercise, diet and weight loss, and then behavioral modifications that you can make in your life to kind of halt this process. In cardiology, the reality is we often see people much later in the stage of this disease, and we're using medications and therapies, invasive procedures, commonly to treat these comorbidities. But all of these can be targeted with lifestyle modifications, as we will discuss. So the first, again, this term hypertension, which refers to an elevation of your blood pressure. How do we measure that? Typically in your doctor's office, of course, with a blood pressure cuff, and that should be happening at every office visit. Also, you can monitor your own blood pressure with relatively inexpensive home blood pressure cuffs, or at any major grocery store will often have access to that, although that's been limited during COVID. What do we call a good blood pressure? This comes up very frequently. So technically, a normal blood pressure is less than 120, which is the top number, or systolic blood pressure over 80 millimeters of mercury, which is the diastolic blood pressure. That's the lower number. That's considered normal. Why that's a little debatable is that we often don't initiate medical therapy until it's a little bit higher, typically in the range of 130 over 90 or so. But importantly, more and more data is suggesting that lower in that range is better. So we should be trying to get everyone to a blood pressure of somewhere in the 120s over 70s millimeters of mercury. If you're above that, then it really is time, certainly, to institute some of these lifestyle therapies and potentially medical therapies as well. Why is that? So elevated blood pressure is a problem for several reasons. It causes damage to the vessels of the body, the arteries, which lead to progression of atherosclerosis, which I'll show in just a second. Two, it causes increased stress on the heart. The heart's a muscle and has to work harder against a higher blood pressure to pump blood forward. That causes thickening of the heart muscle, just like any other muscle in your body. If you're pushing higher and higher weight, it's going to hypertrophy or get larger. The heart muscle does the same thing. And this can lead to abnormalities in the heart function or heart failure. Finally, it can lead to strokes. An acute rise in your blood pressure can lead to a rupture or hemorrhage of a blood vessel in your brain and cause a hemorrhagic stroke. So this is a very important risk factor in the progression of multiple forms of cardiovascular disease. The next risk factor is cholesterol. So abnormal cholesterol, and typically we're talking about high cholesterol, but not always, is referred to as hyperlipidemia or dyslipidemia. When your doctor checks a cholesterol panel, you'll see you get all types of numbers back. You have a total cholesterol, a LDL cholesterol, HDL cholesterol, triglycerides, non-HDL cholesterol, and that can be a little bit confusing. The main takeaway is that total cholesterol and LDL, or low density lipoprotein cholesterol, are typically your bad cholesterols. These deposit into the wall of the blood vessel, which I'll show in just a second, and lead to the progression of atherosclerosis. Triglycerides are likely related here as well. They're causally, they're not necessarily causally related, but they do correlate with increased cardiovascular events. And they're a pretty good reflection of your diet and metabolic health. HDL cholesterol has historically been called the good cholesterol. And in that case, higher typically associates with better outcomes or health, even though it's not necessarily a direct causal relationship there either. In terms of how these correlate to atherosclerosis. So this here is a diagram of a blood vessel. This is the lumen, or the inner portion of the artery. And this is called the endothelium, or the outside of the blood vessel. And what you have circulating through your blood vessel is a lot of these particles. These are each representing a different type of cholesterol particle, and they're circulating through your bloodstream. When we're measuring your total cholesterol, what we're measuring is these little particles within these larger particles, and that's they're added up to form basically your total amount of cholesterol in a given amount of blood. What happens is you get some sort of disruption to this barrier of the blood vessel wall. How does that happen? It happens with what we just talked about, high blood pressure. It happens with what we're going to talk about, which is elevated blood sugar or inflammation. And or tobacco, smoking, can cause a disruption of this barrier, which allows these cholesterol particles to leave your blood vessels and go into the wall of your blood vessels. When that happens, they aggregate. There's inflammatory cells that try to fight them off, and it forms what's called plaques, atherosclerotic plaques, which are deposits of cholesterol within the lumen of the artery. These lead progressively to narrow off that artery, and then when they rupture or break off, you have an acute blood clot form, and that causes a heart attack or stroke if it's in your brain arteries, heart attack if it's in your heart arteries. So cholesterol, the fewer particles that you have going through and the fewer total amount of cholesterol that you have within your bloodstream is going to lead to less deposits of cholesterol, leading to decreased atherosclerosis. This is another picture basically of the inner portion of a blood vessel. So this is your blood vessel wall, and you have this deposit of fat or cholesterol that starts to narrow your blood vessels and lead to decreased blood flow to the heart. Again, if that ruptures off, you get a blood clot there, which is a heart attack. The next risk factor is an elevation of your blood sugar, which again, we call diabetes mellitus or pre-diabetes when it's not all the way. This you're getting monitored in your doctor's office when they check your blood glucose or blood sugar, or a test called the hemoglobin A1C, which looks at basically an average of 3 months worth of your blood sugar. Diabetics and others will use continuous glucose monitors, which give kind of a constant reading of their blood sugar so they know how to adjust their medication. Again, why is elevated blood sugar a problem? For the reason we just talked about, it can disrupt the barrier, leading to progression of atherosclerosis. Elevated body weight or obesity. So what do we consider in medicine to be overweight or obese? We define an ideal weight as a body mass index or BMI, which is just your weight divided by your height, your weight in kilograms over your height in meters squared, yields this body mass index. A body mass index of less than 25 is considered normal. For given heights, this is what weight that those would correlate to. A body mass index between 25 and 30 is considered overweight, and a body mass index greater than 30 we call obese. The next risk factor is inactivity or lack of exercise. This has been very correlated to survival. So a large study that was originally done, originally kind of showing the benefits of exercise, just grouped people into different quartiles by their exercise, basically the energy that they expend into quintiles actually, and grouped by least to most fit, and showed a significant change in the risk of death over several years based purely on the amount of activity that you expend. Tobacco is the last modifiable risk factor I wanted to mention, and I'm not going to spend much time on this. Fortunately, the use of tobacco is decreasing. Importantly, from this perspective, though, is that it's never too late to quit, and the benefits of quitting are seen quite quickly in terms of a reduction of the cardiovascular outcomes that occur from them. Tobacco does lead to progression of atherosclerosis, and it does lead to inflammation and acute heart attacks as well. Again, the additional risk factors that I wanted to briefly mention are just the genetics. are starting to incorporate this into clinical practice a little bit, but it's still a bit premature. But it's coming down the line where we can do genetic analyses just to help to risk stratify someone's risk of developing premature early atherosclerosis, and it allows us to intervene a little bit earlier. And then inflammation we're starting to target as well. So there have been a couple of recent medication trials targeting inflammation that do seem promising for reducing heart attacks. So again, we have medications that target each of these, and I spend a lot of my time doing that. But importantly are the things that we can modify in our lifestyles to decrease the amount of medication we need, avoid medications, and decrease our risk of having cardiovascular events. And again, broadly grouping these into categories of exercise, diet, weight loss, or behavioral interventions. And primarily there, I'm going to talk about some sleep and stress interventions. So how does exercise decrease our risk of cardiovascular disease? Cardiovascular disease, again, is a conglomerate of the very risk factors that I mentioned and showed here. Exercise targets just about every modifiable risk factor here. Of course, inactivity, it does lead to reduction in bad cholesterol, lowers weight, does decrease blood pressure, lowers your blood sugar, and decreases inflammation. Again, can't do anything about the tobacco or family history, but it modifies just about every other risk factor. In terms of hypertension, starting a regular exercise regimen can lower your blood pressure within just 4 weeks. In those with elevated blood pressure, the average reduction in blood pressure is about 5 to 15 millimeters of mercury, which is very significant. It may not sound like much, but a 5 millimeter of mercury drop in your blood pressure significantly improves cardiovascular outcomes. And so that is significant, and that's within 4 weeks. How does it do it? So it's probably mediated by what's called the autonomic nervous system, which kind of regulates your heart rate and blood pressure in response to blood volume. It relaxes the blood vessels and creates new blood vessels to lower the overall pressure. It also acts by decreasing inflammation, which leads to increased blood pressure, your sensitivity to sodium, and decreases arterial stiffness. All of these lead to a lower resting blood pressure. I put a question about resistance exercise training. So when we talk about exercise, we think of anaerobic exercise, which is weightlifting or very short bursts of high intensity exercise, versus aerobic, which is more traditional, longer exercise, biking, running, walking, etc. When it comes to hypertension specifically, resistance exercise training or weightlifting is not necessarily related to lowering blood pressure, while aerobic exercise has more data supporting it. In terms of lowering cholesterol, starting an exercise regimen has shown to reduce triglycerides. Again, these are kind of the fats circulating through your bloodstream, increasing that high density lipoprotein HDL, which is the so-called good cholesterol. And this response is dose dependent. The more exercise you do, and we'll talk about how much exercise to do, but the more you do and the more intensity you do it with lead to greater reductions in cholesterol. In terms of glucose, it does exercise regimens slow the progression or even prevent the development of type 2 diabetes. Type 2 diabetes is the so-called insulin-resistant diabetes. It's often develops later in life as opposed to type 1 diabetes, where you have a problem with insulin creation. But this is insulin resistance, and exercise does slow the progression to that by basically increasing the sensitivity of insulin in your fat tissue and in your muscles. It's been shown that just a single low intensity exercise session results in improved insulin sensitivity the following day. In terms of obesity, again, we're going to talk about diet and exercise here. Diet is probably more important, what you take in, than exercise. You know, you do a bout of exercise, you may burn 300 calories or so. You can very quickly make up for that with a snack after exercise. That said, exercise is very important for maintaining weight loss or maintaining your current weight as part of your regular regimen. But when you're trying to lose weight, it's really exercise alone is not going to accomplish that, and diet has to be a significant portion. Exercise does decrease biomarkers of inflammation. The most common we use when we're testing blood is something called C-reactive protein, or CRP, as a marker of inflammation, and this does come down in our exercise program. So how much should you be exercising? The nice thing is it doesn't take much. Walking for just 15 minutes a day or 90 minutes per week is kind of a minimum effective dose to show a significant decrease in overall cardiovascular events. I put here this RR means relative risk. This is in trials how we define how much a intervention affects. So one trial looked at different exercise interventions and showed relative risk reduction. So running for 1 hour or more per week was associated with relative risk of 0.58 or a 42% risk reduction. Brisk walking for 30 minutes or more per day with an 18% risk reduction in cardiovascular events, and lifting weights for 30 minutes or more per week with a 23% relative risk reduction. The American Heart Association recommends 150 minutes at least of moderate intensity physical activity per week, or more than 75 minutes of vigorous intensity physical activity. Moderate intensity would be you can maintain a conversation while working, but a little bit more than a stroll with the dog. In terms of upper limits, so there are upper limits here. There's really a plateau after about 50 minutes per day of exercise, or 5 hours per week, where the cardiovascular benefits anyways start to plateau, and you don't get a whole lot more benefit cardiovascularly beyond that. You may get benefits in your training if you're training for a specific race or marathon or otherwise, but the cardiovascular benefits peter out around 50 minutes per day. How you get that 150 minutes or 75 minutes is less important. Generally recommend doing that over at least 3 days because of a decreased risk of injury. So if you try to go out and do 150 minutes in 1 day and then take 6 days off, that's much more likely to lead to injury than spreading out that time over the course of several days. But actually, the health benefits are equivocal. It's kind of the total time spent exercising. Similarly, if you're going to do 30 minutes of exercise, they've looked at whether doing 10 minutes 3 times during the day versus a single 30-minute bout of exercise, and it turns out to be fairly equivalent. As a broad recommendation, I get asked a lot, how many steps should I be doing? A reasonable recommendation is try to get 7,000 to 10,000 steps per day. A 30-minute walk is about 4,000 steps. In terms of what type of exercise, we've mentioned this a little bit: anaerobic or kind of weightlifting type of exercises versus aerobic, cardiovascular, running, biking, etc. The combination is probably most beneficial, and probably not best to stick with one or the other. They each have benefits in different, depending on your goals. High intensity interval training, or HIIT training, are intense bouts of exercise where you get up to 80% of your maximum heart rate, followed by periods of rest or lower heart rate. And that actually is a pretty time-effective way to achieve similar goals. In terms of the next lifestyle modification is diet. So diet, similarly, affects many of the risk factors: hyperlipidemia, obesity, hypertension, glucose, and inflammation that lead to the development of cardiovascular disease. So I'm very frequently asked which diet is best for cardiovascular health. There's a lot of diets out there: DASH diet, Mediterranean, keto or low carb, low fat, vegetarian. We'll talk briefly about what some of these are, and the conclusion is less exciting than picking a single diet. So what is the DASH diet? This is the dietary approach to stopping hypertension diet. It's a diet that is high in fiber, which you get through 4 to 5 servings of vegetables, 5 servings of fruits and whole grains; high in protein, primarily from low-fat dairy products, whole grains, poultry, fish, and nuts. And then it limits sweets, sugar-sweetened beverages, and red meats, which leads to lower saturated fat, total fat, and cholesterol, with less than 25% of your total calories coming from fat. What has it been correlated with? It's correlated with lower blood pressure, a decrease of 5 millimeters of mercury or more in those with hypertension, as well as weight loss, on average about 12 pounds over 6 months for those who stick to this, and it can decrease your total and LDL cholesterol. The Mediterranean diet, on its surface, is going to sound very similar. So this is adopted from those who live in Mediterranean areas. It's very high in fruits, particularly fresh fruits, vegetables, whole grains, and fatty fish. Again, low in red meat and saturated fats, emphasizing those meats that are more lean. And with basically substituting lower fat or fat-free dairy products for those that are higher fat dairy foods. Mediterranean diet pushes high oils, particularly olive and canola oils, high nuts, instead of butter and other fats, as well as the use of moderate alcohol consumption, primarily through wine. The reason I talk about those two first, they've been the most extensively studied in cardiovascular disease. There was something called the PREDIMED study looking at the Mediterranean diet, and did show an overall reduction in cardiovascular outcomes in those who stuck to this diet, driven by a decrease in stroke, blood pressure, and inflammation. Another meta-analysis, which looks at multiple trials with the use of the Mediterranean diet, also found a decrease in cholesterol levels and improving triglyceride levels. So the low carb diets have gotten a lot of attention lately, and I get a lot of questions about these. So what is a low carb diet is kind of nebulous, but generally thought of as less than 130 grams a day of carbohydrates. A very low carb diet is less than 60 grams per day. And you'll probably have heard of a ketosis diet. When carbohydrates drop to less than 50 grams per day, you enter into ketosis, where you're using alternate sources of energy. These diets are very effective for weight loss. And then they're probably, if your goal is short-term weight loss, these are likely the most effective diets to accomplish that. However, it is what it is. That's short-term weight loss. So when you look at these diets and compare them to others at longer timeframes, greater than a year, it does not lead to greater weight loss. And the rest of the cardiovascular markers are pretty controversial. Some people actually have a rise in their cholesterol levels upon a low carb diet, but there's quite a bit of heterogeneity. And I think that's driven by what people are replacing their carbohydrates with. So if you're going to replace your carbohydrates with a lot of saturated fat, it's not going to be a cardiovascularly beneficial diet, although it might, again, lead to, in the short term, effective weight loss. There have been a few nice trials that have tried to compare these various diets, a low fat, low protein, low carbohydrates diets, or Mediterranean and DASH diets. Again, most studies show that the greatest weight loss is, and certainly in the short term, come from low carbohydrate diets. But the takeaway from a lot of this is that actually the biggest impact is those diets that people adhere to. And I think this is one of the problems with the low carb and certainly ketogenic diets is they're very hard to adhere to. It's very restrictive in the types of foods that you can eat. And so, a diet isn't very good if you're not adhering to it. And so adherence to any diet in these trials tends to lead to weight loss. And so it's really important to pick something that is sustainable and matches with your food preferences. And if these all seem to match with your food preferences, those that seem to show the best cardiovascular benefits do tend to be the Mediterranean diets. Mediterranean low carb diets both lead to a larger reduction in triglycerides than simply a low fat diet. I didn't mention vegetarian diets. There are many variations of vegetarian diets, vegan, vegetarian, there's a pescatarian with fish and vegetables. And these do tend to lower your cholesterol and can be effective. But again, if it doesn't match your food preferences and you can't stick to it, then it's not worth much. Diabetics have the greatest improvement in their glycemic control or their blood sugar control when they adhere to a Mediterranean diet. So what I tell patients is that this needs to be individualized. I ask what foods they enjoy eating and how we can make some small improvements to get to a healthier diet. And I actually think this is a more helpful way of thinking about it. So American Heart Association actually this year came out with dietary advice. And this is somewhat modified, but there are basically broad recommendations, of which there are 10 in total. And I find these to be more helpful than a prescriptive diet. So one, balance calorie intake with physical activity to maintain a healthy weight. So again, this BMI of less than 25, basically the calories that you expend should be greater than the calories you take in. And so whether that's just pure calorie restriction or increasing physical activity, you have to make sure the energy balance is there if you want to maintain a normal weight. 2, choose a wide variety and eat plenty of fruits and vegetables to get a full range of nutrients from food rather than supplements. So fruits and vegetables are high in fiber. High fiber intakes associated with a reduction in the risk of coronary heart disease and stroke. Choose whole grains. So replacing carbohydrates that have a high glycemic index, which means they shoot your blood sugar up higher, things like white rice, white flour, pancakes, and replacing those with carbohydrates that come from fruits, vegetables, and whole grains is beneficial. Choosing lean and high fiber proteins that come from plants, nuts, legumes, seafood, lean meats, and low fat dairy over red and processed meats. So why? So processed meats should be avoided and cut down as much as possible. They're linked to higher risk of type 2 diabetes, red meat as well, although to a lesser extent. And in terms of the fat intake, saturated fat, if anytime you can substitute saturated fat for polyunsaturated fat, is going to reduce your cardiovascular risk. Notably, if you take fat, even saturated fat, and substitute carbohydrates, that does not seem to reduce your cardiovascular risk. Dietary cholesterol raises a lot of questions. Eggs, which are high in dietary cholesterol, does that lead to cardiovascular disease? Actually, the association is not that clear. So dietary cholesterol does not necessarily correlate directly with the cholesterol we're talking about, which is what we're drawing from your bloodstream. So what I tell people is experiment. And if you enjoy eating eggs, eat eggs. We'll test your blood cholesterol. Stop eating eggs. After a few weeks, we'll test your blood cholesterol. And if you happen to be very sensitive to them, then we probably try to limit them. If it makes no difference, which it often does not, then you can enjoy your eggs. Number 5 is using liquid non-tropical plant oils, such as olive oils and sunflower oils in place of butter, certainly margarine, and high fatty oils like coconut oils. Choosing minimally processed foods rather than ultra processed foods as much as possible. Eliminating trans fats. Processed foods are very linked to increased cardiovascular risk. minimizing intake of beverages and foods with added sugars. This is probably the #1 intervention to make, certainly for weight loss, but also cardiovascular outcomes, is just if you're consuming a lot of calories through drink, that's an easy intervention. It should really be water, tea, and some coffee. And otherwise, calories should come from foods. Choosing or preparing foods with little or no salt. Blood pressure does increase with any dietary sodium or salt intake, and substitution of potassium for sodium leads to significant decreases in blood pressure. Finally, limiting alcohol consumption. One alcoholic drink per day in women, and 1 to 2 maximum per day in men. I'm not saying you need to start drinking if you don't already, but if you do, those should be the limitations. So finally, are a couple of behavioral interventions, primarily here again, sleep and stress, that I wanted to talk about, which can lead to reductions in obesity, blood pressure, blood sugar, and inflammation. So how much sleep should we get? The recommendations, they change by age. So younger children need more sleep. I have children in 3 of these categories here, and so they should be getting quite a bit more sleep, in the range of 10 to 15 hours, although they rarely do, whereas adults should be getting in the range of 7 to 9 is considered normal amount of sleep per night for an adult. 6 hours may be acceptable, but is considered low sleep, and more than 9 hours or 10 hours is considered too much sleep. So the data on sleep is largely correlational, meaning self-reported sleep duration and associated outcomes, which isn't the highest quality of data, but there have been effects seen from this. So sleep duration of less than 6 hours per day over 18 years is associated with a 12% increased risk of obesity, 6% increase of elevated fasting blood sugar, 8% increase in hypertension, and 7 to 9% of hyperlipidemia. Getting poor sleep, less than 7 hours, has in another trial shown to have a 30% increased risk of development of diabetes mellitus. They took people and restricted their sleep for one night, no sleep for one night, versus those who slept, and the next day they had a 13 millimeter of mercury higher increase in their systolic blood pressure. Consistently sleeping less than 6 hours per day over time was associated with a 20% increased risk of having a heart attack over 7 years. Again, notably, more than 9 hours per night was also associated with increased risk. So why is this? Likely mechanisms. Inflammation is a probable mechanism here. Again, that lab value that looks at inflammation, C-reactive protein, or CRP. After a poor night of sleep, those inflammatory markers are elevated. It can also affect your appetite. Hormones called leptin and ghrelin, which regulate your appetite, are altered after a short sleep duration. Similarly, after a short sleep, you don't typically increase your energy expenditure to make up for that. So you have an increased appetite without an increase in your energy expenditure, leading to weight gain. One study with consecutive sleep restriction of about 2 hours resulted in increased insulin resistance, which again is going to increase your blood sugar and decrease glucose tolerance. There's a condition called obstructive sleep apnea, where people frequently stop breathing for short periods of time throughout the night. Obstructive sleep apnea is very correlated to cardiovascular outcomes, primarily mediated through an elevation of blood pressure. When you stop breathing and you're waking up throughout the night, even if you're not aware of it, it activates the sympathetic nervous system, and you have increases in your heart rate and blood pressure. By using treatment for obstructive sleep apnea, which is most commonly CPAP or positive airway pressure, you do see a reduction in blood pressure. So finally, some is stress. So stressful situations have been correlated to an increase in your overall cholesterol levels and blood pressure. They've shown this in tax accountants in the month of April, students who are taking exams, and following significant life events or job loss, that cholesterol and blood pressure have increased. It does tend to return to normal following removal of the stress. They looked at individuals who were bullied and found an increased risk later in life of type 2 diabetes. Another study looked at medical students and asked about their levels of anger. And they found that those who had the highest levels of anger by the time they reached 55 years old had a 3.5 more likely risk of having significant heart disease. Similarly, anxiety is independently and significantly associated with MIs, which myocardial infarctions or heart attacks. So if we treat stress, can we improve outcomes? Yes. So adding stress management to cardiac rehab, which is a program for individuals with cardiovascular disease, led to a nearly 50% reduction in cardiovascular outcomes, which includes heart attacks, strokes, need for further procedures, or death. One study looked at transcendental meditation and shown benefits primarily through a reduction of blood pressure, improvements of insulin, and a reduction in myocardial ischemia, or decreased blood flow to the heart. So in conclusion, we have these risk factors, this American Heart Association Simple 7, hypertension or high blood pressure, hyperlipidemia or high cholesterol, diabetes, which is elevated blood sugar, obesity, which is an elevated body mass index, inactivity, diet, nutrition, and tobacco. And on top of that, there's genetics and family history, which we can't currently alter, and the presence of inflammation. And these are really, when I see someone in clinic who wants to reduce their risk of having cardiovascular disease, we talk about each of these and what methods, both lifestyle and with medications, we can take to make sure these are all decreased as much as possible. The lifestyle modifications primarily being exercise, diet, nutrition, and then some of those behavioral modifications. So that's exactly 6:45. So we have time for questions again, or I can pass on my information to ask questions at a later date.
Great, thank you, Dr. Simon. We'll go ahead now and take some questions. Just a reminder, please type your questions into the Q&A chat box located probably on the bottom of your screen. I do see we have a few questions already in the queue. The first question is, my resting heart rate is in the 40s. A home sleep study showed my heart rate dropped to as low as 28 beats per minute for a short period of time, with a corresponding drop in oxygen saturation to 84%. My primary care physician didn't seem concerned, as it was a very small percentage at the time. Would you agree that this is a low pulse or not concerning to you?
Yeah, so there's more to that. A pulse in and of itself is not dangerous. A low pulse, a heart rate of 40 by itself does not necessarily signify a problem. The question is whether there are symptoms associated with a low heart rate. So there are abnormalities of the electrical system of the heart, which lead to a low pulse rate. And that can certainly be a problem. But they're typically manifested with symptoms: lightheadedness, exercise intolerance, not feeling well. If you feel perfectly well and your pulse is 40, then it's likely not a problem. Whether that's a significant oxygen drop, I'd have to see the full report of whether that's a significant sleep apnea, and it depends how frequently that's occurring as well. But that is a typical response. So during a sleep apnea, the heart rate does drop significantly. And so we see that pattern where the heart rate will drop significantly during an apneic event. So basically, need more information, not always bad, but it could be.
Great, thank you, Dr. Simon. Next question. What do you think about COQ supplement for those DX with cardiovascular disease? Or are there any other supplements that help with modifying inflammation?
Did you say, is it coenzyme Q12? Is that what I think we're probably asking about? And yeah, so here's the problem with supplements. It's a poorly regulated industry. And so what I mean by that is that just about anyone can put a supplement on the market, and it doesn't have to go through the same process as prescription medications. So they're a little bit harder to study for that reason. And what you buy on the shelf is not necessarily what is studied. That said, coenzyme Q12, yes, there are some indications of benefit in terms of reduction of inflammation. I often put people on that when they're using a statin, as it can mitigate some side effects that people often experience with statins. So I think that's a perfectly safe supplement with some indication of benefit in cardiovascular disease. And you know, the others I would talk about on an individual basis. Again, there's huge variety in where you're getting supplements, what you're taking them for. And so across the board, no, I don't recommend any supplements across the board for all comers. It really depends on what it is we're trying to treat.
Great, thank you. Next question. Can you ask your provider for a CRP blood test?
Yes, it's pretty common, cheap, easy test. Anyone, there's going to be heterogeneity here in terms of what the providers do. Often they will check a CRP along with a cholesterol panel. It's just another marker of risk. Some providers don't do that. I wouldn't fault them for that, but I do think it's a nice kind of additional risk factor when you're looking at a cholesterol panel to say, okay, you're a little bit high, but your levels of inflammation are quite low. We can sit on this for a little bit. But if your inflammation levels are considerably elevated and you're borderline, I'd say we need to treat this. So it's kind of a tiebreaker in some senses.
Great, thank you. Next question is, my calcium score is 850 with a family history of heart attacks and death. I'm 70 years old with a BMI of 22, and my current cardiologist has me on meds with no concerns. Should I be concerned?
Yeah, so, coronary calcium is an interesting one. We could have a full chat just about coronary calcium. When I showed that picture, so those plaques that develop along the outside of the artery, what happens is over time, those actually stabilize. They become chronic and calcified plaques, which are actually stable, meaning they are unlikely to break off and cause a heart attack. So coronary calcium scores are very helpful because they give a sense of what's going on underneath. So do you have atherosclerosis? Yes, you do. The picture I showed, that's what you have. That's developed over a long period of time, and you have atherosclerosis, which means we do need to put you on medications which reduce those risk factors. So should you be on medication to reduce your cholesterol? Yes, almost certainly. But the calcium is actually stable. And so it's not a marker of how likely you are to have a heart attack next week, but it does signify that you are at higher overall risk and that process has occurred. Should you be worried? Should you do anything beyond medications? I'd have to look at the case and see which medications you're on. If you're completely asymptomatic, you don't need to do anything else. If you have symptoms of exercise intolerance, chest pain, shortness of breath, et cetera, then I typically will do a stress test in individuals with a high calcium score.
All right, great, thank you. Next question. A recent echocardiogram revealed occasional PVCs. Is there anything I should know or do or be concerned about?
Potentially. My next step there, so I think it's probably an electrocardiogram that you're referring to, which is just a 10-second strip of your heart rhythm. And if you're having multiple premature ventricular contractions, or PVCs, which are extra heartbeats over the course of 10 seconds, then the next step that I do is what's called a Holter monitor, or a home monitor, which you wear for between 48 hours up to 2 weeks, and it counts the total number of those extra heartbeats that you're having. The extra heartbeats in and of themselves are not dangerous, but if you are having a high proportion of those at all times, meaning more than 15% or so of your total heartbeats, then that can be associated with a reduction of overall heart function, and that does need to be treated. If the overall burden of those premature ventricular contractions, PVCs, is less than 15%, 10%, then it's fine to just continue to monitor.
Great, thank you. Next question, is fish oil good for heart health? Does it help reduce triglycerides?
Yeah, it's a good question. Fish oil, this falls into this similar issue I said with supplements. So it depends. So fish oil comes in multiple varieties. There's something called DHEA and EPA. And there have been really high quality studies of a purified fish oil called icosapent ethyl, and showed significant triglyceride reduction and reduction of cardiovascular events. So yes, in that sense. However, what you buy over the counter is not purified EPA fish oil. So what you're buying and taking over the counter, I do not know if that leads to a reduction of your triglycerides or your cardiovascular outcomes. But yes, in a purified EPA, I do put patients who have elevated triglycerides and have cardiovascular disease on this. It's called, the trade name is Vascepa, VASCEPA, and that does reduce the risk of having a subsequent heart attack.
Great, thank you. Next question is, my husband has thrombocytopenia. I apologize, I'm saying this wrong. Does he have a higher risk for CV? Thrombocytopenia. Sorry. Do you get what I'm saying?
No. Thrombocytopenia, maybe? How's this?
Yeah, that's right.
Thrombocytopenia?
Yeah, that's what it looks like. It's THROMBOCYTOPN.
Okay, thrombocytopenia.
ENIA, yeah.
Great.
Thanks,
okay.
Shelby.
And then what was the question? Is there a higher risk of what?
For CV.
Not necessarily. No. No. It's not directly associated. I would look at those other risk factors as more guides to his risk than just thrombocytopenia.
Great, thank you. And next question, after you have a heart attack, is it too late to benefit from cholesterol lowering drugs?
Oh, great. Absolutely not. Absolutely not. In fact, the data is much, much stronger for those who have had a heart attack in reducing death and future heart attacks. The data is fantastic in terms of statins, another medication called ezetimibe, and a new class of agents called PCSK9 inhibitors, which all significantly lower cholesterol. The data is much stronger for people who have had a heart attack than for those who have not. So absolutely not too late. Absolutely, you should be lowering your cholesterol if you've had a heart attack with medications. It is too late. It's not too late to do the dietary and lifestyle modifications. Those are important, but it's too late to get away with just doing that. Once you've had a heart attack, you also need medications.
Great, thank you. And next question, This is from a story. When you go to the doctor for an appointment and they walk you in and sit you down to take your blood pressure right away, which seems to give a little bit of a false reading. I really noticed this with my mother when I'm with her. She does have breathing issues, asthma. So when I get to her to take a few deep breaths and have them do the rest of the evaluation before taking the BP, that does help.
Yeah, no, great point. There are defined protocols for taking blood pressure, and any blood pressures taken outside of that protocol should really be thrown out. And so that does involve sitting comfortably in a chair with your feet on the ground, flat, your arms at your side for 5 minutes and resting. We see this all the time. People are, I spend half my time at the university. The parking there is insane. You're running in from, across the parking lot. You're already late for your appointment, and your blood pressure is through the roof when the medical assistant takes it. That's not an accurate reflection, and so I always will retake a blood pressure in those circumstances. And you're right; it often comes down significantly.
Great, thank you. The next question: should I take one aspirin if someone suspects I have a mini stroke?
Yes. If someone told you that you had a stroke, even a mini stroke or a TIA, transient ischemic attack, then yes, you should take 81 milligrams of aspirin unless you have some sort of bleeding contraindication. Yep, lot of news headlines recently on aspirin. Again, I could spend an hour talking about aspirin. I actually have a interview through UCHealth that's available on specifically this question, which we could send out as well. But yes, anyone who's had a stroke, anyone who's had a heart attack should be on a daily aspirin, 81 milligrams per day, unless they have some contraindication, which is typically a bleeding issue.
Great, thank you. And last question I have for you tonight: are you accepting new patients, and how can our attendees find you if you are?
Yes, I am. And so my clinic that is the most open is at the Lone Tree Center. So just calling the UCHealth Lone Tree Center, which can be done online as well through My Health Connection. You can book an appointment. And yes, I'm seeing new patients there. I actually also am starting specifically a cholesterol clinic, a lipid clinic and prevention clinic in March, which will be at the university hospital. But for now, the Lone Tree Clinic is the best place to get in.
And for those on the line, that's just south of Park Meadows Mall. It's about 8 miles from Highlands Ranch Hospital to the east, if you're not familiar with Lone Tree. They have great parking. It's easy to navigate Lone Tree parking. So it's not, it's a little bit easier than navigating Anschutz Medical Campus. So.
Absolutely. And the cardiologists, at all the UCHealth sites are really fantastic. And I collaborate with them frequently, and you can't go wrong. The Highlands Ranch Hospital cardiologists are fantastic as well. We've partnered with a lot of these talks and things with them. I work with them at times over at university as well. So any of them, I feel you are in good hands.
Great, thank you. And thank you again, UCHealth, for giving us the opportunity to learn more about men's health from Dr. Simon. Thank you to all of those who joined us this evening. Our next virtual health event will be on Wednesday, February 2nd on pain management. Thank you for joining us, and have a great rest of your night.